supposed to would be a little bit far like that.
Okay.
So that will not boom boom distortion. Yes. بحاول اخليها تكون بعيدة. بس إذا نفع
Testing, testing, testing. Okay.
أقول لك
Testing, testing. Yeah, can you?
Okay, ladies and gentlemen, we'll start again with Dr. Khan.
Thank you. Okay, can we dim the lights a little bit, please? All right. So before the break, what we talk about is when we do immediate, the buccal bone is always needed, right? As long as the interproximal bone is there. So let's take our thinking process one step further and take a look at this patient here, all right? This patient is actually from Lebanon, okay? She's Lebanese, and she studied her medical school in the States and in Seattle, and she flew to Seattle to see me. The problem is her right central incisor, okay? And what happens is at her young age, she was jumping up and down on the trampoline, and she flipped and she fell out and the face hit the floor. Avulsed the right central incisors, thereafter multiple endodontic and periodontal procedures. This is a situation right here, all right? So is this a good case for immediate implant placement? What do you think? Absolutely not. In fact, if you push here, every once in a while you see some white creamy things come out. Kind of remind you of the cream of mushroom soup type of things. So infection, no bone. How do we deal with cases like that? Now, traditionally, most surgeon is going to do what you call extraction, clean everything out, and do the bone graft later on, the delay method. However, on a patient with high smile line, something like that, and aesthetics is paramount importance, sometimes, as you know, once you extract the tooth, the bone and the gingival architecture may begin to compromise. And you know, if you look at this case carefully, despite all the problems this patient have, but the gingiva do look good. Why? Because the tooth is there to support the gingival architecture. My dear friend Frank Spears always tell me that, Joe, what holds the gingiva is the presence of the tooth. Because once you lose the tooth, you notice the gingiva start to collapse down. So how do I deal with this type of situation? This situation is very funny. I had discussed this case with Marie Salamer, Frank Spears, Dave Matthews. Oh my goodness, a lot of my friends. I called them up and they say, well, and I treated this case more than 20 years ago. I was just a young student. I called them and said, what do you guys think? And they didn't give me a really concrete answer. Most of people tell me, extract the tooth. Maurice tell me, extract the tooth, and then implant and just bone graft, maybe 3 or 4 tissue graft. Then I started thinking, you know what? I cannot do that to my patient. So basically, this is the defect right here. Obviously, there's no bone for immediate implant placement. And a lot of times, when I set up my surgery cases, I always start with the prosthetic in mind. You notice the patient have a lot of composite on the adjacent teeth, and that they need to be restored, and also the gingival level is not at the right level, so those need to be addressed. So what the office did is in 2003-4, they think of this concept called the PRRPG. What the concept essentially is, if the gingiva is intact, such as this patient, but the foundation is compromised, such as this patient with the infection, maybe what happens is, rather than extracting the whole tooth out, we remain a portion of the tooth in place and then clean out all the defect site. Now, how do you clean it out? Well, basically, you do what you call, first you decontaminate the infected site, then you reconstruct it, all the while preserving it. So how do you do that? To preserve the gingival architecture, first you section the root and remove the diseased portion. Where do you section it? Roughly 3 millimeters from the free gingival margin. Why is that? Because typically that's where you as a surgeon is going to be putting the platform to implant. Then after that, you clean out the defect, and then you're going to reconstruct the defect, let it heal, all the while using this tooth fragment to preserve the gingival architecture. So when you enter the site, you can see the damage have been done over the years, all right? So really go in there, and then typically curettage is not enough. You literally need to take a burr, a round burr, slow speed handpiece to go in there and just remove a layer of the bone surrounding the destructed area, because bacteria have been harbored there for years. So just curettage alone is not enough. Then in this situation, I use a combination of, bone morphogenic protein and then membrane. And then now this is 8 months after the healing. Remember, the root had been sectioned, all right? And then bone had been regenerated right here, all the while preserving the tooth fragment. And you notice that, despite that, the gingiva still look good because the tooth is still there, right? And then we decided to do some corrective procedures, perio procedures for the patient, because she had multiple perio grafting done. So I decided to go do some cleaning for her, and then just put a little free gingival graft there just to dermabrate the tissue, just clean it up, and let it heal so that it's not as, as grotesque, all right? Then, so this is 5 months after the healing. That means this is 8 months after bone grafting on top, 5 additional months after the soft tissue healing. Then we do the implant placement, immediate implant placement, but this is the key picture. This is after I remove that tooth fragment. You can see this is solid bone that I regenerated from the foundation. Then place the implant, and then do the tissue graft, just like what I talked about, the scarf tissue graft at the pharyngeal margin area, and the screw retain provisionals. So you can see this is the healing over time, and then the healing over time, 5 months. Then I re-enter site. In those days, long time ago, I do a lot of flapless crowning filling surgery, which I seldom do anymore, because I noticed, just like what the literature has said, that when you do flapless crowning filling surgery, a lot of times you get a lot of tissue rebound. Okay? But anyways, provisionalize the patient, and then definitive restoration. All right, definitive restorations. So you can see the crowns right here with the implants. All right. So this is a 15-year follow-up. All right. I just saw the patient just a few weeks ago. So patient flew from Seattle to see me. Now she's a physician. But when you look at this type of results, how did we get this type of results? If you try to think about it, if I extract the tooth and do GBR and tissue graft, multiple graft afterwards, do you think I will even get close to get these results? I don't think so. The reason we get these results is being conservative. Because remember, sometimes we need to think outside the box and be creative. We know that as long as the tooth is there, you can utilize it to maintain all the bony architecture and reconstruct it. The key is almost like leaving an ovate pointing in the equation, and then extract it at the very last moment, okay? The special thing is when I see my patients over the years, they grow old with me, and it's extremely special. So anyways, let's look at our all-maxillofacial surgeon here. How do we deal with this type of situation? Remember, we talked about when the buccal bone is intact, buccal bone is compromised, what happens when there's no buccal bone? So, our old surgeons, when he came to me, he already been to 5 different specialists in Beverly Hills, in Los Angeles. She said, Dr. Ken, a lot of people say you are very good, that's why I want to come to you. Now, years ago, let me tell you, when a patient came to you and said, you are very good, that's why I come to you, I feel very good. Now, I'm actually more scared than anything, okay? Because you know you cannot make mistakes. So I take a look at the radiograph. This is what I see. Now, when I see this, I am not happy. Why? Because sitting right next by the tooth that's failing, someone some time ago had placed an implant on the left central incisor. Now, it makes things even more complex. Because not only the patient have no buccal bone, but if I put an implant in there, I'm in an inter-implant situation. That means 2 implants right next by each other. Now, you all know the difficulty of putting two implants right next by each other is the papillae, right? Do you know why? Let me show you why. You can see this is the implant that has been placed some time ago. If every time when you see an implant that has been placed some time ago, I want you to look at the bone sitting right next by it. More likely than not, this is what you see. In other words, if you look at an implant and you look at the radiograph, and you know that implant had been placed more than 5 years ago, if you look at the bone sitting right next by the implant, more likely than not, you will see a vertical or infra-bony pocket pointing towards the implant on both sides. You can see it here too. All right? That is classical. The longer you wait, the more you see this. Now, what is the concern? Does this bother me? The answer is no. Because we know that a lot of times when we probe interproximally, the probing depth tends to be probably close to 4 to 5. Seldom go beyond 6 because the literature has shown on the Journal of Periodontology 2003. That article, they do the measurements from the implant platform to the papillae. They found out that on an average, the dimension is 6.2 millimeters. All right? Because of that, a lot of times when you do periodontal probing on a single implant, the measurements on an average, you probably get between 3 to 4 millimeters. That's pretty typical. All right? Now, like I say, despite this bony defect, we seldom see the patient come in with peri-implant mucositis or peri-implant implantitis. Not that often. Therefore, this is not my concern. However, what bothers me is that piece of bone sitting right next by the pocket here. You'll notice that, again, if an implant has been placed for a long time, not only you see the bony pocket, but you will see that this piece of bone that's sitting next by the tooth that's failing now gets thinner and thinner and gets sharper and sharper, like this. Then you say, all right, if you need to put two implants together, one of my friend, Dennis Tanau, said, you got to keep a certain distance between the two implants, 3 millimeters. You remember that, right? But let me tell you, I don't know how many of you surgeons out there try to put 3 millimeters at least between two implants, and yet your papillae is compromised. All the time, right? So it's not so simple. Do you know why Dennis Tanau say you need to keep a distance of 3 millimeters between the two implants? Do you know why? To maintain the papillae, this is the thinking process. This is the thinking process. Let me give you an example. Do you mind? I need 2 persons to help me here, 2 persons. Can I have 2 persons to help me? Do you mind come and help me? Can you come on stage? Come. Right here. Come. Can I have one more person? Let me see. I want a different person. Do you mind? Do you mind? Thank you. Come on up here. Come. Here and here. Each facing this way. Face the audience. Yep, face the audience. Perfect. Now, this is a situation. We have 2 implants. One implant. This looks like a wide diameter implant. This looks like a narrow diameter implant. 2 implants, okay? Now, why did Dennis Tanau say that you need to keep 3 millimeters of distance between the 2 implants to minimize papillae loss? This is the reason why. Okay? This is the top of the implant, The crown is here, okay? The crown is here. Got it? Incisal edge is there. So, what happens is, remember, once you put the implant in for a while, on the platform of the implant, you start having the bony pocket, right? The bony pocket. So that means if I'm the implant here, that means the bone became like that, like a bony pocket. Got it? The bone. So, may I have your hand? Just raise your hand like this. There you go. So you have a bony pocket, higher. There you go. You have a bony pocket, right? And then can you do the same? There you go. Bony pocket right here, right? Now, this is the situation here. Every implant has a bony pocket. But if the distance of the 2 implants get too close, okay, come closer a little bit, closer, okay? Don't need to touch your hands, just come forward a little bit, and then just go like that, just come over. If the 2 implants too close, guess what happened? This bony peak and this bony peak cross over. And then this become bone loss, you understand? That's why dentists now say, move over a little bit, move this way. Come far away, because every time when you have a bone loss on the implant, based on the classical periodontal literature by Hell, this bony pocket seldom exceeds more than 1.5 millimeters. You understand? Therefore, dentists say, if you keep the distance 3 millimeters, this bony peak will never cross over. Therefore, you maintain the bone there. You understand that? Thank you so much. Thank you so much. Appreciate it. Thank you. Thank you. That's the reason why. You understand? So therefore, they say keep the distance apart. But the thing is, it's not so simple. Because once you lose the teeth, a lot of times, the supercrestal fibers also will become compromised. Therefore, even without bone loss, because of lack of supercrestal fibers, the papillae will automatically lose almost 2 millimeters. Therefore, even keeping a distance of 3.5 or 4 millimeters may still not be enough. Then you say, then what? Let's say now, if I extract this tooth and I put an implant in there. All right? Typically, the surgeon always put the implant at the level of the facial bone. Because of that, the interproximal bone is always more coronal than the implant platform. Understand? Now, what do you think will happen to this piece of bone after you extract this tooth and put an implant in there? What do you think will happen to this piece of bone? If you are Japanese, they will tell you, sayonara, gone. And if that piece of bone is gone, what do you think will happen to this papillae here? Likewise, it's going to disappear. Therefore, that's one of the reasons why. So let me repeat. If you have 2 teeth failing, the bone usually looks like this. 2 teeth, the bone here. But if you have 1 tooth, 1 implant and 1 tooth, the bone usually looks like this. Therefore, if you need to replace 1 implant like this, with an implant sitting next by, it's more challenging than replacing 2 teeth, because the bone is thin like this. Then what do you do? What do you do? How do you manage that? Then you say, all right, how about if I'm going to leave a piece of root right here? Don't remove the whole tooth, just leave a piece of root here. Will that help to maintain this bone here while you have the implant there? Therefore, the concept of root shield. Now, what do we know about root shield? Okay, this article actually in 2013, what the authors talk about is, they say maybe in inter-implant situations, we leave a fragment of the root to maintain the papillae between the 2 roots there. All right? That was 12 years ago. Now, how can we apply to this? Basically, there's no buccal bone. This is like a high-risk case, all right? Because ideally, the root should be healthy, no periodontal disease. This tooth, the good thing is there's no mobility. So I section the root, remove the diseased portion, leave the fragment of the root intact, something like this, and you can see the root here essentially is holding up this papillae. You see that? You see the root here, the papillae. The existence of this papillae because of the presence of this root. All right? Despite the implant being placed in there. Okay. So again, you look a closer look, and a lot of times, once you extract the tooth, if you remove the root, the implant platform is there, this papillae will probably go down to all the way down to here. Okay? So you can see, put implant in graft, throw my tissue graft in. Now, if you look at the suture on this picture, it doesn't look good at all. Trust me. A lot of times you see people take pictures after suture, they look perfect using microscope. But I don't worry too much even the suture doesn't look perfect, because that's this thing called biology. If you understand and respect the biology, the healing will always take place where you want it to be. All right? So you can see this is a healing over 1 year. After 4 months, well, because the surgeon wanted me to change the crown on the left central incisor, so I put 2 provisionals in here after 1 year. But I want you to look at the papillae from before to 1 year later. It almost hold the position, all right? And then after that, when I remove it for the definitive impression, all right, you see the presence of that papillae there. Now, some of you look impressed, but let me tell you, the results of this is not because of my surgical skill at all. Here's very little to my surgical skill, but everything to do with because the tooth is there, all right? I will tell you that doesn't matter how great a surgeon anyone is, it is hard to duplicate these results because we fool nature as if the tooth is still there, right? Then we do the definitive restoration, okay? The implant is, this is a screw retain. This one is an old implant. They don't have those angle channel abutments, so I need to do a cement retained. So this is the final result. But when you look at a 7-year follow-up from before to after, all right? Correcting facial tissue problem is not a problem, but I want you to look at 2 implants right next to each other, ladies and gentlemen. Why do you get this kind of results? The papillae basically did not move. Why did it not move? It's not because of me, because of biology. How do we know about that? Well, does root shield really work? This randomized controlled clinical trial, we teamed up with my dear friend Marcus Herser and Otto Schur from Germany. And then we're looking at this multi-center study, looking at comparing immediate tooth replacement with and without root shield. Does it work? How does it work, okay? I'm going to show you some really preliminary data because this study will be completed by next year, March, and will be submitted to the journal next year, all right? But I'm going to give you just one part of preliminary results. What the authors did is, for the first time, they did what you call volumetric analysis. Now, volumetric analysis is very tricky. If you read the literature, people always say volumetric analysis. The word volume is the tricky part. Why? Because if you understand all those digital dentistry, all the geometric, software, those kind of things, you notice that all the volumetric analysis, the name is a misnomer. Why? Because volumetric analysis essentially is never measuring about volume changes. It's just measuring a whole bunch of dots with linear changes and try to stitch it together. So it's an estimation of linear vertical changes. But still, the literature still called volumetric analysis, all right? But what is so different in this study is this. Remember, there's a soft tissue and hard tissue zone. The authors separated, I believe, first out the literature, evaluated the changes in soft tissue zone versus a hard tissue zone. All right. This is a soft tissue change, hard tissue zone change. Key point to bring home. Something very interesting. If you're a big fan of root shield, I have bad news for you. Why? At 1 year, regardless whether you use the root shield or just tissue graft, the changes is negligible. That means there's almost no changes, no difference. And if you look at the hard tissue zone right here, yes, there's some, but the change is not that significant too. So I don't know about you, at least in 2022, at this point, okay, I feel that is there a big benefit keeping a piece of root on the facial aspect of the tooth to maintain the buccal contour? Well, of course, with root shield, you can maintain better. But then there is technique sensitivity, and then also the risk of problem is high. I'm not sure we should consistently leave a facial shield just to maintain the facial contour. Maybe if you want to lecture, just to show off, maybe, okay? But the interproximally is the key right there, okay? Why? Because this article will be published in a few months in this journal called the International Journal of Peri and Restorative Dentistry. For the first time, this group of authors evaluated what happens to the papillae between two implants if you hold a piece of root between. Let's take a look at what we learned from this article here. All right? They look at 26 inter-implant papillae with the root shield. This is the key. After almost 3.5 years of follow-up, the mean papillae loss is 0.5 millimeters. That is huge. Because I'll show you data later on. If you don't have the shield, the average papillae loss is 2.5 through 3 millimeters. So, if you have a patient with high smile line, and if everything, the tooth condition is good, interproximal root shield may be a potential rescuer to the situation. In fact, I was having dinner with my dear friend Dennis Tandau just around a month ago in Phoenix at the American Academy of Periodontal meeting. And I talked to Dennis about root shield. He said, you know, Joe, I think that to maintain inter-implant papillae, root shield, there's something special about root shield, for sure. All right? So, now, for example, this patient, she's a dentist. Okay? She's actually a periodontist. She flew from out of state to see me because of failing right, left 8 and 9. Okay? So, I discussed with her, because aesthetics is paramount, I say maybe we should maintain the root there. She agreed, just to keep the story short. I removed the palatal fragment of the root on both teeth, leave the root shield facially, put the implants in, and you can see what we learn now is the shield just need to go from line angle to line angle. That means we don't need to wrap it all the way around. Got it? And then you can see right here with the provisionals. This is 6 months healing. Again, inter-implant papillae. The papillae may have blunted out just a little bit. Again, it's not because of my surgical skill, it's that root shield. And so if you look at it 1 year, and I remove it for definitive restoration. Again, I'll tell you, in my career, I can do all kinds of tissue graft, bone graft. The chance of me getting this result is almost 0. Okay? Definitive 2 individual crowns. Okay. 6-year follow-up. 2 implants. Okay? So I want you to look at this picture. This is on the day of surgery. Remember? Implants, the shield. Okay? I want you to look at right here. This is so important because if you look at the papillae, there's a cold between the papillae, a cold, right? There's a buccal aspect of the bone, palatal aspect of the bone. A lot of times when we do surgery, doesn't matter how meticulous you are, maintaining that facial aspect of the bony peak is almost impossible. A lot of times the facial bony peak will disappear. All you have left is the palatal bony peak. Therefore, you see the papillae, shorten out. And sometimes if you're unlucky, you lost both the buccal and palatal bony peak. But look at this here. At 6 years, because they're screw retained, I removed the crown just to take a look at it. You can see the results here. Okay? And she is probably as picky a patient, as picky a periodontist as I can treat. So you look at it. All right? All this because of the shield, the presence of the shield there. Okay. Right? So, again, I think in 2022 today, is it controversial to do the shield? I think it is. However, even in the surgical discipline, in perio, I think they're thinking about it. You know why? Because earlier this year, the American Academy of Periodontology contacted me, the headquarters. They say, Joe, we are seriously considering having me on the podium to do a live root shield surgery at the annual Academy Perio meeting. So that is just telling you that I think we have long enough data that it is more than an experimental procedure if it's done correctly. So now, how does the papillae compare, inter-implant papillae compare using different methods, like the delay method? Delay means you extract the teeth and put 2 implants in. How will the papillae hold up? One after another is the technique advocated by a publication in 2003. What the authors suggest is if you have 2 teeth that are failing, you first extract one of the 2 failing teeth, put an implant, and put a provisional in. Wait for 6 months for the integration of the first implant. Then you extract the second failing teeth and put an implant and provisional in there. By doing so, hopefully to help maintain the papillae better. So, what does this study show? This is the key right here. Let me make sure I walk you through. This is papillae loss. This is 0 is no loss, minus is loss, okay? This is the root shield group. This is the range of loss. This one, delay. Delay means extract the teeth, let the whole soft tissue collapse, do implant and tissue graft. This is simultaneous. That means you extract the teeth and do 2 immediate implant placement. This is simultaneous with provisionalization. That means you extract the 2 teeth and put provisionals like that right there. You get probably slightly a little bit better. One after the other is what I described to you. But when you compare to root shield, nothing can come even close to the presence of that fragment of root there. Okay? Sometimes it's humbling. A lot of you are great surgeons out there, but you know nothing beats the biology, unfortunately. So with that in mind, let's go to our last patient here. Okay, what do we learn? This patient basically have a failing right central incisor, and the problem is there's no buccal and palatal bone. So how do we deal with this case here? Is this a good case to do immediate? What do you think? Absolutely not. This is not a good case to do immediate, right? So how do we manage cases like this then? How do we deal with cases like this? First of all, my recommendation, extraction first. You always extract the teeth, okay? Then, how do you deal with the scenario or something like that? You can see that we have a vertical defect there. When you have a vertical defect, how do you manage vertical defects, okay? How do you manage vertical defects? So this is a situation. When you manage vertical defects, how many of you have done vertical bone regeneration in this room here? Vertical bone regeneration. Do they work well? Okay, I'm going to show you this patient. This patient was traveling in Europe. She's from the United States. She was traveling in Eastern Europe. While touring, a very old tree suddenly fractured and slammed against her face and knocked out her teeth. She came back to United States, went to UCLA maxillofacial surgery department seeking for help. And then the UCLA maxillofacial surgery department called me. Hey, Joe, can you give us some idea what do you think is the best to treat of this? And then, so we took over the case. This is what happened. We look at the teeth. The teeth should be right here. Patient's a young girl, beautiful looking girl, missing all this tissue. Now, how much bone can we regenerate vertically? What do you think? How much bone do you think we can regenerate vertically? If you read the literature, they'll tell you that at least you can regenerate up to 12 millimeters of bone vertically. The question is, does it work? Remember, East Van Urban was my graduate student. I know how everybody's work is like, all right? So What happens is we decide to do surgery on this patient. Now, I wasn't the surgeon here. The surgeon who did this surgery basically flew to come to our center to do the surgery. I guarantee you that if the surgeon who do this surgery, if you were to rank the top 3 most famous bone regeneration surgeon in the world, right now, this person belongs to top 3. Okay? The day of the surgery, this is the flap, this is the bone. So I asked him, what's the plan? He take his finger, he wiggled the patient's left central incisor. He was moving a little bit. He said, we must take this out. I said, why? He said, I do not want to do vertical bone augmentation when the adjacent tooth has mobility. I say, okay, you're the surgeon, it's your call, I'm just standing here to assist you. Extract the tooth. Now, the goal is to do vertical augmentation, to bring the bone down, all right? So basically use a combination of xenograft and autologous bone, 50-50%, and do vertical augmentation. And then he takes what you call the cytoplasm membrane and punch some holes around there to give better blood supply. This is 1 year later. After this, he said, well, the bone is not enough, we're going to do a second graft. We'll put implant in, using xenograft for the second graft and use barrier to graft there, right? So this is the implants. You can see a bone. And then did a second, like a connector, 3 gingival graft, just to firm up the tissue there from mucosal tissue. Now, because after 2 grafting, the bone is still not sufficient, the soft tissue. Therefore, the game plan is to do profile. I know Ali Quad always say there's no such thing as profile, but I'm going to call it profile prosthesis. That means use artificial gingiva, right? Finish. So what's my point? Roughly 1 year later, I got a call from the patient. Patient said, I need to see you, Dr. Ken. I say, why? The patient said, because my general dentist told me, you need to go and see Dr. Ken. So she returned 1 year later. This is what I see. Humbling. I want you to look carefully. Look at the radiograph here. This implant looks okay. This implant looks okay. Why is this implant okay? Because it was placed in right here. The implant on the right looks okay because it was placed in bone. The area that was grafted, majority of it is gone. So I can tell you, it's very humbling. Vertical augmentation. Does it work? What is the thinking process here? Let me just walk you through quickly. This is another patient of mine, has a defect like this. What goes through in my mind? Okay? This is the defect size. Again, it's vertical augmentation. What goes through in my mind? What works, what doesn't work? These are the things that I always think about when I do vertical GBR. First of all, I look at the adjacent teeth bone and period. What does that mean? This is a defect. I look at the adjacent teeth. What is the periodontal condition? Does it have mobility? Where is the bone? Okay? Why? I look at the mobility for this particular patient. No mobility. Then the next thing is I look at the bone on the adjacent teeth. Despite this defect, you see the bony peak right here. Why? Because I know if I draw a line connecting the bone on these 2 teeth, No matter how I graft, I cannot graft beyond this 2 lines here. How do we know that we cannot graft beyond this 2 lines? Because, so for example, this patient here with defect, I put a tenting screw here. I try to graft beyond to gain some attachments here and throw some endo gain in here. Okay, let's see what happens. All right, membrane, graft over it, over grafted. 10 months later, you can see the bone basically stay at where it is. The bone a lot of times will go down to where beyond this line, but not above this line. How do we know? Because this study is going to confirm it. I believe the first time in the GBR history, a clinician evaluate when they try to regenerate in partial redenture situations above the bony peak. Can you regenerate above the bony peak intentionally, and what is the consequence? Okay? This is what they find out. When they try to go GBR coronally to the 49 interproximal bony peaks, 8 months later, this is how you see. Most of the time, you go back to 0. A lot of times, you end up losing some of the bony peaks. Therefore, it confirms once again, when you do vertical regeneration, you most of the time cannot regenerate above the interproximal bony peaks. Okay? Then secondly, prosthetic design. A lot of times when we have big defects, it's the prosthodontist or the restorative dentist that should take the case in the first place. First step. Why? Because they need to create the prosthetic design where things supposed to be. Then the surgeon need to rebuild the soft tissue to where the prosthetic is supposed to be. All right? And once you know that, you know the size of the defect. You know how much you need to regenerate. And you need to look at the different possibilities there. All right? The next thing is you look at the thickness and condition of the existing tissue. Sometimes it's often neglected by the surgeons. Why? Because nowadays, before I do any bone augmentation, I always evaluate the quality of the soft tissue first. Is it thick or thin? Is the tissue very friable, like this one's here? For example, let's look at this patient here, all right? With defect, actually was referred to a dear friend of mine who's a maxillofacial surgeon. And so basically, I go in there and I saw this, I go in there, I clean things up, and I do the regeneration procedure, all right? This is the day of the surgery. I see something like this, I should have never proceeded with the surgery. I should have maybe do a tissue graft to repair it before I do the surgery. Because how many of you have ever done bone augmentation or tissue graft that you see that there's a fenestration or dehiscence on the soft tissue? And all you do after grafting is you take some suture and repair it. Do you know usually what will happen? The case will blow up. Either expose or blow up. So here I did a block graft. So suture to repair the defect. You can see the defects start to proliferate. I mean, this type of cases happen all the time. Therefore, nowadays, therefore it compromises the underlying bone. Therefore, nowadays, when I do regeneration, I always make sure that the soft tissue condition need to be at its prime condition. If it's not, I either do tissue graft to repair to make sure it's in prime condition. All right? So when you look at, for example, this patient of mine was another referral. Patient had an implant placed by some surgeon in LA, has some problems. And so you can see the defect here. So before I even do the regeneration, what do I do first? Well, this is how the patient first came in, and the surgeon removed the implant, and of course come in with a defect like this. All right? So this is a defect. But the first step is not to do the bone regeneration. First step is to try to repair the defect. There are many ways to repair it. This is one such way. I just do a rotational palatal flap from the palate and just sling it over to try to repair it. And then I put some, what they call bio-os collagen, just to hold the soft tissue so it won't collapse on me. And then try to repair the defect. We want the tissue to be as in prime condition before we do the bone augmentation. Then we re-enter the site, and in this situation, we do the bone augmentation using autologous bone there. All right? So that's the thinking process right there. Now, going back to our patient, what else do we need to consider here? Flap design. How do you guys raise the flap when you guys do bone augmentation? Because when you do the flap design, let me put it this way. I want you to focus in the crestal region. When you make an incision, you can either make an incision crestal, palatal, or facial. What path will you do? Facial, crestal, palatal. Most of you palatal. Me too, palatal. But you know what? For years and years, I always do palatal incision. Then the last 6, 7 years or so, I realized that I've been doing something wrong. What is wrong with palatal incision? When you compare facial, crestal, and palatal, what I did is I compared all my guided bone regeneration cases comparing what happens to 3 different incision design crestally. Which one has the highest chance of exposure and necrosis? Guess what? Palatal is the worst one. Therefore, in my practice, you hardly see me making incision from the palate anymore. I either go crestal or facial. Then you say, why, Joe? Actually, I was so stupid until I realized that, you know what? When I read this article published in 2005, when they do analysis, look at the blood supply, the facial and the palatal, this is the crest of the ridge, guess what? If you make an incision right here, you're cutting off all the blood supply. The best incision based on this article is the crestal incision when your blood supply is coming from both sides there. You understand? So the key is very simple. Making the article say that palatal incision increase necrosis is very simple. So stay away from making incision from the palate, either crestal or facial, to minimize problems. Now, another issue with palatal incision. For example, this is the situation here. You're going to be doing this is called facial, that means this is where you make the cut, crestal and palatal incision. See that? Now, when you make the incision like that, why is there more problem with palatal incision? Let me explain to you why. So you're going to do a GBR. This is the palatal flap, the facial flap. You're going to reflect it and you're going to do a GBR, right? So you're going to do a GBR right here, vertical GBR. Now, what happens when you make the flap incision at different point? How will that affect your graft? I want you to look carefully. Crestal incision. If you make a crestal incision, once you raise the flap, you do a GBR, what happens? The palatal flap will become shortened, right? Because there's a bulk of material here. So to close, what do you need to do? You're going to pull the facial graft like this, right? You release and pull the facial graft. Understand? Now, what is the problem here? Remember, palatal flap cannot be pulled. You can only pull the facial. This is the problem. When you are trying to make a crestal incision, you're moving the flap all the way to here. The blood needs to go all the way to here to support this area. is a long distance. On top, you have the periosteal releasing incision extensively to free the flap out. Now, you know what gets worse? If you are the type of surgeon that believes in when I do my GBR, I'm going to put a soft tissue graft here too. That's like committing suicide. Why? First, to survive, everything needs blood. Your bone graft needs blood. Your flap needs blood. If you put a piece of connective tissue graft here, what will that tissue graft do in terms of blood supply? Is it giving blood? They also need attention. Please give me some love. I need some love too. Everybody needs love. And you throw a tissue graft that needs love too. Just imagine that. That's like a bomb waiting to happen. Therefore, for me, in 2022 today, if I'm going to do regeneration, if I need tissue graft, I'm going to do it beforehand or afterwards. I'm not going to do it most of the time. I'm not going to do it at the time of the graft. All right? So that's crestal. All right, how about palatal? This is what happened. It got even worse. Why? Imagine, palatal incision, your palatal flap is even shorter, right? And now, your blood needs to travel even further to get to this point. You see that? That's why, how about facial then? This is what happened facial. Because you make an incision facial, when you reflect the flap is long here. You understand? So, your facial flap doesn't need to travel very long to get to where it is. And not only that, one of the key success to regeneration on flap closure is to evert the tissue. Why? Theory tells us that you want intimate contact between the periosteum to periosteum between the two flaps. Therefore, the eversion. Why? Because periosteum also provides the blood. But I want you to think, ladies and gentlemen, comparing to this type of incision design and this type of incision design, which one is the least effective to evert the flap? When you make an incision like that, when you try to close, how many of you can evert this flap like this? Impossible. Dreaming, fantasy. So therefore, for me, I either go crestal or facial based on what I know that probably will minimize the chance. And honestly, when I look at my career, when I make crestal or facial incision, the exposure rate crestally is around 10% or less. Therefore, in 2023, at least with my limited experience, I will almost never go palatal incision. All right. I'm sorry? 50, perfect, thank you. So therefore, you go like that, right? You just go and facial incision, just to keep the story short. I just do this is a defect. I decide to do some bone grafting here. Just keep it. Let me just move forward a little bit here. Sorry, I'm going to jump forward just a little bit. So in this situation, I use autologous bone and basically graft it. Okay. And usually we wait for around 4 months for the bone to heal. Last but not least, flap tension. How much tension it provides to flap, will that play a role in the success or failure? This article by MP Lang said yes. What they did is they used an instrument to measure the flap tension. This is what they find out. The greater the flap tension, the greater the chance of flap dehiscence. The lesser the flap tension, the lesser the chance. So let me tell you, do you know what's tension-free flap? This is tension-free flap, okay? What I do for tension-free flap in my practice is this, okay? Most people, when they do tension-free flap, they release the periosteum, they take a tissue forceps, grab the flap and roll it over the crest of the ridge. If they can do that, that's called tension-free. For me, that's not tension-free. What tension-free for me is this. So nurses retract, I release the periosteum. After that, I pull the flap to the crest of the ridge. With my forceps still in place, I tell my nurse, remove your retractors. After that, I let go. This is what I like to see. This is called tension-free flap. That means the suture is just to hold the flap. It's not to pull to close it. That's called tension-free, all right? And when we do it like that, we notice that. So this is another case, just an example. I did a big broad graft here. I just hold the lip. You can see the closure right there. No suture. That's what I want to achieve in my practice for tension-free flaps, okay? And then, in fact, flap release. How should we release the flap? So when you reflect the flap, the soft tissue here between pharyngeal margin to the attached tissue tends to be thin. As you go to the mucosal tissue, it widens out. Most clinicians, when they do the tension-free releasing incision, this is what they do. They'll go in there and, so they reflect the flap, they take a blade and start cutting. And they try to pull. Wrong. When you cut like that, you do more damage than good. The key is not about going here. The key is to go here. This is a zone you want to release, not this zone here. Just imagine, this zone here, all you do, if you cut it here, when you pull, that's tension. But if you cut this way here, that means what you do is this. You go this angle. Your blade, I actually barely cut. I just scorch the periosteum. I want to release it following the vestibule direction. That's how you're supposed to release the periosteum. Okay? So anyways, going back to our patient, this is the healing at 8 weeks and then 9 months. So when we entered the site at 9 months with the autologous bone, this is what you see. And then remove it and put implant in. Okay? So you can see there's plenty of bone volume right now. And then I do another tissue graft at the neck of the other tooth to get this. So the point is this, when we do bone regeneration vertically, like this, our patient here, how we manage it is, I flap it. You can see this is the bony peak. There's loss of attachments here. And we can seldom gain bone on the loss attachments area, which I'll show you on this case. Okay? So I did a block graft again. Why did I use PIF? I don't know why, because the machine was given to me, so it's for free, so I use it. I don't know why I use it. I don't think it does anything, honestly. I haven't seen any difference on any of my cases. But you can see, I try to graft over the attachment loss area. Okay, so graft, then suture. This is a CBCT. After graft, 4 months. We enter the site at 4 months. Picture on the right, you can see. Now, remember I tried to graft over the lost attachment area. I want you to look carefully. What do you see? Just a piece of bone sitting out there, do nothing. So therefore, we can seldom graft above the interproximal bony peak. Guided surgery, prosthetic-driven guided surgery. And then closure. When I want to train the tissue, I seldom put a provisional on the heel side. I see many surgeons, sometimes they do implant in heel size aesthetic zone, they want to put a provisional in there. I don't, because the best way to train to get the soft tissue the way you want it to be is to submerge everything. Then you conservatively, so you can see the defect and where I place the implant. Then we conservatively, incrementally expand the tissue at second stage, something like this. Incrementally using provisionals to expand the tissue. Because once you put a provisional in heel size, the tissue is basically stagnant. You cannot change it anymore. So I want to go, when you want to train the tissue, you want to go from small to big. When you want to maintain the tissue, you want to go big. You understand? Let me repeat. If you want to maintain the tissue architecture on the failing tooth, you go big. That means your provisional need to be the size of the tooth. But when you have nothing left, you want to train the tissue, you go from small to big. So you can see we train the tissue the way I want it to be, the shape of the tissue of the provisionals, and usually it takes around 3 months to do so. Definitive restoration. Okay. And I just removed the provisional just to show you how the tissue heals and everything. I mean the final crown. 6 years follow-up. CBCT. Okay. So basically, we'll wrap it up in just a few minutes here. This is what we learn is this: when you don't have enough bone, when you extract the tooth, you always want to put bone graft, but when you do bone graft, you may not preserve the facial tissue at all. It's still collapsing. So what did you learn? We learned that you need to leave a gap 1.5 millimeter facial to the implant, and then the socket size is what dictates the implant diameter. Why? Not facially, but incisally. Because when you look at this patient here, incisally, the buccolingual dimension is 7 millimeters. Therefore, if you can put an implant in there, you will not put a 5 millimeter diameter implant on this patient. I end up putting a 3.5 millimeter diameter implant in there. All right? Why? This is a key point to bring home. To dictate implant diameter is a buccolingual dimension that dictates the implant diameter, not the facial, not the mesial distal. And the only reason you use the mesial distal dimension if it is the small of the two. Why is that important? Because when we look at these classical publications by Ash in 1974, when they measure maxillary and anterior teeth buccolingually at the cervical region, this is the average dimension, 6, 5, and 7. Now, unfortunately, if you look at the central incisors, that means the average buccolingual dimension is 6 millimeters. So, what size, how wide does the tooth need to be in order for you to comfortably put a 5 millimeter diameter implant placement for the central incisor? What do you think? Well, if 5 millimeter, facially you need to add 2, palatally you need to add 1. So therefore, if the buccolingual dimension of the tooth is less than 8, it's not going to work. Therefore, you know what? When you do your digital setup, your digital waxing, the buccolingual dimension is so important, right? Now, why is that even more important? Because this to be published articles. They duplicated this study, but with digital planning, CBC scan. They measure against central, laterals, and canines, 400 sample size each. If you look at orange, the mean dimension is the same as 1974. But this study has some range. You look at the range. Look at the central incisors. Over 400 sample size, the upper range is not 8. Therefore, if you plan a 5 millimeter diameter implant placement for a patient's central incisor, I challenge you to stop and ask yourself 16 times, should I do it or not? Because in my practice, before I understand this concept in 2003, 40% of my implants are bigger than 4.5 millimeters. Once I understood this concept, less than 1% of my implants are greater than 5 millimeters. So put everything in conclusion. This is what you learn. In immediate implant placement, central incisors, buccolingually, less than 7 millimeters. You want to leave a gap more than 1.5. You also want to leave a gap palatally. Therefore, most implants, the last 12 years, this is the average dimension of implants I place for central incisors. 66% 3.5, only one case 5.0. So, if you allow me, give me 5 more minutes, I'm going to wrap this up right here, and I want to finish with this patient. Do you remember this patient? This patient came back 16 years later from India to remind me that, Joseph Ken, you are not so good after all. How did I treat this patient? For you, you see recession. For me, I see gaps too. You see gaps between teeth? Why are there gaps? Why are there gaps? I checked the occlusion. She started having wear on the posterior teeth and started having slight anterior traumatic occlusion. Okay? Sometimes patients' wear pattern change over time as they age. That's understandable. I told the patient, you know what I can do? I'm going to send you to my orthodontist, have them slanderize the mandibular anterior teeth, orthodontically retract the teeth back to allow room, restorative space, and then put you on braces on the maxilla, bring them back, and then I'll deal with this tooth here. She said, no, Dr. Ken. Once you started trimming in the United States, when I go to India, I'm not sure who to turn to. I'm a little bit scared. I'd rather not go this direction. I say, okay, then plan B. If you are okay with me, I'm going to take a burr and do some enamelplasty, create some room, have the orthodontist retract the maxillary teeth back, and once everything is done, and if you need to go through to India, I'm going to remove the brackets, put you on an S6, and every time you come back, we'll continue treatment. She said, I like that idea. Good, that's the plan. How about another reason for gaps? What else can cause gaps? How about if you put an implant on a patient's growth hasn't completed? What is the youngest age where you put an implant on a patient? What is the youngest age? 16? 17? 18? 19? 20? 21? 22? 23? Do you guys do implants? What age? What's the appropriate age? Well, let me tell you. This is surprising. I always thought that it's okay to put an implant when they're 21 years old. But now I realize I am wrong. Why? If you look at this article by Bernard at the Journal of Clinical Perio, what they did is they compared two groups of patients, the young patient and the mature patients. All right? And this is what they find out. They look at the cast over time. On implants placed in the aesthetic zone, comparing the young group and the old group, this is what they find out. Over 4 years follow-up, all has infra-occlusion and gap developed between the teeth and implant. Or the youngest, when you put implant between 15 to 21 years old, the oldest between 40 to 55 years old, you have this problem develop. Yeah. What is going on there? What is going on there? All right? So, in fact, when I look at my data on female and male patients placed implant at different age group, you'll notice that the male, once after 20 years old, no problems. But the female group, it lingers. In fact, when I look at another wonderful periodontist friend of mine, Odette Bahat, they tell us that there's this thing called delayed development. It happens a lot to females. We must be careful. So what do I do in my practice? I try to hold back as long as possible, probably 24, 25 years old before I place the implant in female. Male, after 20 years old, I'm okay. In fact, if you look at our patient from India, how old was she when I placed the implant in? 24 years old. 24 years old has this problem. All right? So what was the problem? What caused the problem? I go back to 1997 on the day of the surgery. I make an impression of the implant. This is 1997, okay? This tells me everything. Why? Because number one, okay, I put a 5mm diameter implant on the central incisor. Number two, I took this scan in 2013 when she returned 16 years later. On this central incisor, I measured the buccolingual dimension, 7 millimeters. 7 millimeter socket, I put a 5mm diameter implant in there. Good or bad? Terrible. This is the day of the surgery, flapless surgery in 1997. You can see the hex position, same position. Third problem, I put the implant to buccal. I should leave at least 1.5 to 2 millimeter distance. I put the implant to buccal. So, 3 problems. Implant too big, too buccal, no graft in the gap. 16 years later, patient came back telling me something went wrong. So, why did I put the implant so big and so buccal? This is the first article ever talk about immediate tooth replacement in the history, in dentistry. 1998, the first ever publication by Worley. Look at, they say, to optimize situation, the socket must be completely enclosed by the implant. And if the root is even bigger, you need to put the implant buccally to engage the buccal bone. OMG. Then the Atlanta team from University of Penn, David Garber, Maurice Henry, this is what they did for us in 2001. Look at that. They say, immediate tooth replacement. The diameter of the implant needs to match the mesial distal width of the socket. Use a big implant to fill the socket is a must for the success. I wonder, will these people dare to show all the cases they've done 20 years ago? I don't think so. Because most of them must be terrible, without a doubt. Anyways, when you have a recession, how do you treat the recession? Do you do bone graft, tissue graft? In order to treat the recession, you must find out what causes the recession. I can tell you at least 7 to 9 things that cause recession. I'm going to show it to you right now. Recession of an implant can be caused by the prosthodontist. The crown or the abutment's too bulky. Or the patient's ginger is thin, or patient brushing too aggressively. Or when that bone is thin or there's no bone. Or when the implants are placed too deep, too big, or too buccal. Those are all the possibilities that can cause recession of our implant. If you want to treat a recession, you must find out what causes the problem before you treat the problem. Now, if I were, if you look at it here, if I were to number them 1 to 4, how would you number them? How would you number them? That means 1, 2, 3, and 4. 1 is the most dominating factor that causes recession. 4 is the least dominating factor. How would you number them? Which one is 1, 2, 3, and 4? What do you think? If it's up to me, this is how I'm going to number it. What I'm trying to tell you is this. When there's a recession of an implant, the primary cause is either the restorative dentist problem or the surgeon problem. So, if the problem is caused by the crown, abutments too bulky, how do you solve the problem? You remove the crown, reshape them, flatten out the emergence. If the cause of the recession is the ginger is thin, what do? That's why you put the sashimi in there. If the cause of the problem is no buccal bone, what do? That's when you do kypher bone regeneration. Now, if the cause of the problem is implants too deep, too big, too buccal, what do? What do? You remove the implant. So let's go back to our patient from India. What is causing her recession? First of all, is the crown and abutment too bulky? What do you think? Yes or no? What do you think? How many say too bulky? You're saying my crown, Joseph Ken's crown, is too bulky? Yeah, it's too bulky because now you want to create something like that. So check. Is the patient's gingiva thin? Check. Does the patient have no buccal bone? Check. Is the implant too big, too buccal? Check. You know, Quarter, this is a case that made me famous. When I look back, I did everything wrong. How humbling. So I take the patient to the operating room. I anesthetize her. I just make a little tiny slit incision. I don't even dare to make a full flap. I just want to take a peek. Kind of like watching a horror movie, you know. Something bad is going to jump at you. And I know this is a problem. And I know what I need to do to solve the problem. I remove the implant. How many of you have ever surgically placed an implant and you need to remove it? How does that feel? Terrible. But I bet you, I must be the only one in the world that had placed an implant, and then I publish it, and I became famous, and I need to remove it. I got to be the only one in this world. Patients say, I'm not flying back to India without a tooth. So I found a piece of bone palatally. I put a small implant in there. I utilized patients' existing provisional as a crown, as a provisional. I put some bone graft in there. The suturing looks so bad because there's nothing to work with. I just try to patch it up as close as I can. You probably never see suture look so bad before. I just want to quickly finish the surgery, go home, go straight into the shower, turn on the shower, let the water mask my tears, right? You know how it feels. So, she stayed in Los Angeles for 2 months. This is a 2 months appointment. When I finished seeing her, you know what? Quarter, she told me that, Dr. Ken, unfortunately, I need to say goodbye to you. I must go back to India. I said, good. But then she looked back at me and said, but Dr. Ken, I will be back. So she returned exactly 1 year later, April 2014, looking like this. And I told her, you know what? I have a master plan. The plan is I'm going to make your adjacent teeth look a little bit longer. You're going to look perfect. But she told me, Dr. Ken, can you please don't touch my good teeth? Can you just fix the problem? You know what I mean? So I said, okay, let's do a second surgery. Go in there, change to a screw retained provisional using the Zucchelli technique, deeperize the papillae, and go in there and do a second bone graft, and then tissue graft. All right, coronary repositioning, initiate orthodontics. Okay. 2 months later, she looked like that. She need to go back to India again. But you know she'll always come back. And you know what? Every time Quarter, she'll always come back in April. I don't know why April. So the last 3 years, April have been pretty bad for me. Okay? So she returned exactly 1 year later, 2015, looking like that. I say, okay, we're going to do one more tissue graft. But she said, actually, Dr. I'm okay. I say, all right, so we go with the final crown. Not perfect. This will be the last slide here. 25 years. Okay, 25 years. She actually just saw me April this year. When she emailed me Sunday, she said, Dr. Ken, I need to see you. I say, why? But this is how she looked like. Last question. When you look at these two pictures, look at the picture on the far left, look at the picture on the far right. Look at the results. 1997, I just finished my graduate school. Okay? I did this case, this is a result. And then, 16 years later, it looked like this. When I see this, do you know how much effort I'm willing to put forth to correct, make this case better? 100%, more than that, 1,000,000%. It's kind of like Return of the Jedi, you know what I mean? And then 16 years later, I'm this famous Dr. Ken already. My ability, my knowledge is much better than now. I tried very hard. This is the results. Ladies and gentlemen, when you look at these two pictures, which photo do you think aesthetically it looked better? This one or this one? Use your finger to point for me. This side or this side? That you like better. Don't worry about my feelings. That's very hurt already. It's okay. Carter, what do you think? Which side you like better? What do you guys think? How many say this side? There you go. Look at how humbling. No, it's truly humble. That's why I'm going to tell you. Sometimes my students say, Dr. Ken, you're so humble. There's so little to be so boastful about. You know what I mean? Medicine is so humbling. Once there's a problem, even you use the best ability and you're on top of the world, you still cannot change it back into perfection. You can only try. So ladies and gentlemen, again, it's a privilege to speak in this beautiful city. Can I hold this flag? Can I hold this flag? Yeah. No, really, thank you. Thank you for making me here. And I will tell you that, dentistry, I hope you learned a few things today, okay, about immediate implantation, the different variation to treat it. And dentistry is not simple at all. We must be vigilant, we must try hard. You know what? I remember in my career, one of the mottos I always use is a motto by a philosophy by Aristotle, the great Greek philosopher. One of the things he said is, excellence is not an act. Excellence is not an act. Rather, okay, basically is a habit. What that means is to achieve excellence not because you did a case, it looks beautiful and you keep showing off. Excellence is you do cases along the way, you have a lot of complications, failures, but you keep going. But not going blindly, but you keep following the biological principles, the mechanical principles, and keep improving, building it like a habit. Eventually, that philosophy is called excellence. My dear friends, it is absolutely a privilege. Thank you.
Thank you, Dr. Khan, for this insightful lecture. We appreciate it. Unfortunately, we don't have any time for questions. If you have any question, please ask it privately. Just please accept our small appreciation for your presence here, and thank you for sharing your knowledge again.
Thank you so much. Thank you. Thank you. Thank you very much. Thank you very much. I'll take that. Thank you. Appreciate it. Yeah. Okay. Thank you so much. Thank you. Yes. You're welcome. No. I just need to, don't worry. Oh, let me get this thing.